Magnetic resonance imaging, that is MRI, of the brain can be learnt in one day. Since invention of Röntgenogram, that is the X-ray imaging, in 1890s, many advances have occurred in the field of neuroradiology like myelogram, angiography, bone scan, computerized tomography, that is CT scan of brain, magnetic resonance imaging, positron emission tomography, that is PET, it can be PET CT, PET MRI, SPECT, and many more investigations. But all these investigative modalities may not be relevant in every patient, so a judicious decision should be taken for advising an investigative modality in a particular patient depending upon the clinical presentation. Magnetic resonance imaging, that is MRI scan of the brain, the development of this non-invasive neuroradiological investigation, that is without any exposure to radiation, made a major impact on the investigative approach of intracranial lesions. MRI helps in early and precise diagnosis of many neurological diseases and helps in their treatment. The high resolution images of the brain structures in multiple planes, like multiplanar imaging of brain in axial, coronal, and sagittal plane, and availability of different sequences like T1 weighted image, T2 weighted image, FLAIR image, DWI, that is diffusion weighted imaging, tractography, GRE, and different techniques like functional MRI, MR spectroscopy, MR angiography, etc. of the intracranial pathologies helps in the management of neurological diseases. So, how MRI is different from CT scan? The CT scan uses radiation in the form of X-ray, but MRI doesn't use any radiation. Here the magnetic field is involved. Okay, so it is safe in certain conditions like in pregnant ladies, and there is a no risk of any radiation hazard. Moreover, in MRI as compared to CT scan, the resolution of the anatomical and pathological structures of soft tissues is better than CT scan. The images are high resolution. Moreover, in MRI, there is, because the compact bones are they appear hypointense, that is relatively black, and they don't affect the images of the very uh, soft structures which are adjacent to the uh, bony structures. In CT scan, the structures adjacent to the hard bones like petrous bone, they are not have very clear resolution. That is called beam hardening effect. But in MRI, these structures like brainstem, it appears very clearly. You can see the crus cerebri, midbrain, pons, other structures very clearly in MRI. The CT scan is only axial images. In sometimes some other planes are reconstructed, but MRI has a distinct advantage. It is multiplanar. Multiplanar means there are axial images, coronal images, sagittal images. So one can have a 3D view, three dimensional orientation about the location of the lesion. It means anatomical details are better in MRI. In CT scan, you find there is only one type of images until unless contrast is given, then only the contrast CT images. But in MRI, there are different sequences. The common one which we see in all MRI films, that is the T1 weighted image, T2 weighted image, flare image, DWI image. These are the common in almost all MRI images. And moreover, different techniques are also used, like the functional MRI, MR spectroscopy. It means MR spectroscopy tells the chemical, gives an idea about the chemical nature of the lesion. Functional MRI, although it is MRI, but it gives an idea about the function of that particular region which is under imaging. And MR angiography, in this the vessels are seen. So MRI is the better investigative module in technique as compared to CT scan. Magnetic resonance imaging utilizes magnetic field as its imaging source, so there is no radiation hazard. In clinical practice, MRI machines are usually 1.5 Tesla or 3 Tesla. There is a gantry and an attached stretcher on which the patient lies. The part under investigation lies in the wide central aperture of gantry of MRI machine. MRI has vastly improved the diagnostic accuracy of diseases of brain. MRI scan of brain is the investigation of choice in patients with diffuse axonal injury, in cerebral infarcts, brain tumors, CSR infections, multiple sclerosis, and spinal cord injury. MR spectroscopy provides the clue about the nature of the lesion and helps in identifying infective and neoplastic lesions of the brain. Intraoperative MRI is an advanced technique for intraoperative imaging of lesions inside the operation theater. MRI images are usually black and white. There are T1 weighted images, T2 weighted, flare, diffusion weighted images. If contrast is given, then it is the T1 contrast images. This slide is very important. Here I am giving you an idea how to know whether this particular MRI image is showing T1 weighted or T2 weighted. Very easy to identify the T1 weighted image. See the location of the ventricles. You know that brain contains ventricles, and inside the ventricles there is a CSF. So lateral ventricles are in the center of the brain and they contain CSF. If CSF appears black, okay, then it is the T1 weighted image. On CT, usually axial images are seen, but as I told you, on MRI, axial, coronal, and sagittal images are seen. So, on T1 weighted image, CSF will appear black. Here in MRI, we say hypointense, hyperintense, and these are in comparison with certain. Like if you are using the term hypointense for CSF, it means it is hypointense as compared to brain. If any structure which appears more white on MRI, then it is called more white, means in comparison with the brain, if it is more white, it is the hyper intense. So on T1 weighted image, CSF, whether it is the spinal cord or brain, CSF will appear hypo intense. It means CSF will appear black. On T2 weighted image, the same CSF will appear white, that is called hyper intense. On FLAIR is the flow attenuation inversion recovery image. The intraventricular CSF will appear black, but the edema associated with any lesion will appear white. So, edema is very easily identified on FLAIR images. Then contrast images. Contrast is usually taken on T1 contrast. It means normally how you will identify whether it is contrast image or T1 image, because in T1 the CSF will appear black. Normally blood vessels are not seen on MRI because the flowing blood doesn't produce signal, that is called time of flight technique. But if on T1 images you are able to see vessels, you see the vessels, you know that in Sylvian fissure the middle cerebral artery runs, like wherever you expect this blood vessel or venous sinus like superior cestus sinus, transverse sinus, like if these vessels are seen, then it is the contrast image. Okay, and this is the way to identify the lesion also, because certain tumors like meningiomas are homogeneously enhancing tumors. Okay, certain lesions show contrast enhancement like granulomas. Again, to simplify the things, that there are terms like isointense, hypointense, hyperintense. Structures which appear more white as compared to brain are labeled hyperintense. Lesions which show similar picture on MRI as compared to brain are called isointense. The lesions or anatomical structures which are having less white than brain are hypointense. These structures are more black as compared to brain parenchyma in that particular sequence of MRI. How to identify a T1 weighted image of MRI? See the center of the brain imaging where ventricle is located. Cerebrospinal fluid is contained inside the ventricle and it appears black, that is hypointense in T1 weighted image. Similarly, CSF in other places like cisterns are basically the dilated CSF spaces, at the base of the brain to protect the soft brain structures against the hard bony prominences. And certain systems are named according to the structures around it, like prepontine system, cerebellopontine angle system, like this. There are certain systems, cisterna ambiens, interpeduncular system, suprasellar systems. There are certain common systems. Then the CSF is also content in the sylvian fissure and in all around the cortical surface of the cerebrum, that is a sulci and gyri. In the sulci, the CSF is also content. So see the CSF in all these locations. If they appear black, it means it is a T1 weighted image on MRI. Now see this MRI. This is the MRI picture in front of you. You see the first row. In first row, there are three images, and in the last three images have a different orientation. Okay, similarly the same is seen in this all 1 2 3 4 5 6 rows, and there are 6 columns. You can see the first three images in all 6 rows, it is basically a coronal image. In coronal image, you see the MRI, it appears that that person is looking towards you. You see the both eyes are seen. In the third image in first row, the both eyes are visible. Similarly, in the first image in second row, both eyes are visible. Okay, this is possible only in the coronal images. Okay, and these images are taken from front to back. Therefore, the first three columns are the coronal images, and we start from the anterior aspect, and you just see the sections anterior to the posterior. In first you don't find anything, in second you see both frontal lobe, then third image you see both eyes, and now you proceed to the second row, and first image again the posterior aspect of the eye is seen, and you can appreciate the terminates inside the nasal cavity. And brain, you see both cerebral hemispheres are seen. It possibly it is a frontal lobe, both frontal lobe. Then in this third image of the second row, ventricles, lateral ventricles start appearing. Then you proceed to the third row, you see that first image both lateral ventricles are seen, but in the second image of the third row on the coronal view, you see there is a whitish lesion. Whitish lesion which is white, equally white as like the CSF in the ventricles. So it is a coronal T2 weighted image where the characteristic of the lesion is similar to the CSF. Okay, this lesion is hyper intense, and when we proceed on the coronal sections backward, as I told you, images are taken from front to back, anterior to the posterior. Again you proceed, and in this fourth row, third image, you start seeing the brainstem, and in the second last row, the first image, second image, third image, you start seeing cerebellum, and when you in the last row, first, second, three, you see the only the posterior, that is the occipital lobes on the coronal sutures. Now you proceed towards the last three columns, which are basically sagittal image. Sagittal is easy to remember. As for side, it means sections are taken from side. So now you see the you can appreciate that there are images which show that as if patient is looking towards the side. Eyes, only one eye is seen in the first, that is in the fourth image of the second row. You see this sagittal image, and there one eye is seen. Then you can have this as if the person is cut from side, that is starting from the ear towards the other ear. So this here is again the brain is seen, then eyes are seen, you can see brain stem, all things are seen. It is just to show you that in the second last the image, you see start seeing the lesion which is white in structure, and its intensity is similar to the CSF. It means lesion is hyper intense as compared to brain. This MRI shows that how is the coronal suture and sagittal suture is coronal and sagittal images are in MRI. These are the axial views of the MRI where the lesion appears as a hyper intense as compared to CSF. This image is axial view of MRI of the brain. Here there are T2 weighted images in first three columns. You see the CSF inside the ventricle is white, that is hyper intense as compared to brain parenchyma, and the area adjacent to the left sylvian fissure, that is the territory of the middle cerebral artery, that appears white. In the last four images of the last four columns, these are the diffusion weighted images. You see here the anatomy focus is not on MRI anatomical details, it focuses on the diffusion of the brain, because in T2 weighted images you see the outermost, that is the white circular thing, is basically the fat of the scalp. It is not the bone. Bone is just beneath the scalp, and that is black. That is the difference between CT scan and MRI. In MRI, the bones are hypo intense as compared to brain, but in CT scan, bone is hyper dense. It means it is white as compared to brain. Therefore, in MRI, the outermost circular layer is the fat. Here in MRI, fat appears hyper intense because it contains more protons, more H hydrogen. That's why it is hyper intense. Then in diffusion weighted image, this is very important investigation to identify the acute infarct that appears very much hyper intense in MRI when done in patients presenting with stroke. Stroke is of two types. One is the hemorrhagic stroke where brain hemorrhage occurs, and another is the infarct or ischemic stroke. When patient presents with ischemic stroke in emergency, sometimes CT may not detect the hypodensity, or there may be still the changes are not visible on radiology. But if MRI is done, it immediately shows very much hyper intense in the infarct territory. Therefore, this investigation is very important for diagnosis of the acute infarcts. I will repeat the same thing several times during this presentation just to make it clear and make it very simple that the mastering the art of interpretation of MRI starts with very basic thing. It is just to understand what is the axial view, coronal view, sagittal view, what is T1, T2, flare image, diffusion weighted, GRE images. These are the basic things. Therefore, again I am highlighting that one with a very basic concept, that see the center of the brain imaging where ventricle is located. Cerebrospinal fluid is contained inside the ventricle and it appears hyper intense, that is white, as compared to brain in T2 weighted images. See CSF at some other places like cisterns, sylvian fissure, and sulci over the cerebral cortex, convexity, which appears white hyper intense in T2 weighted images. When we talk about neuroanatomy, then it means study of the brain, spinal cord, cranial nerves, spinal nerves, nerve plexuses, dermatomes, muscles and joints supplied by these nerves. At the outset, it seems very tough to master neuroanatomy, but it is very interesting and very easy to learn. How to identify contrast MRI image? The contrast MRI utilizes gadolinium contrast, which is injected inside the vessel in veins. The contrast MRI is usually T1 weighted contrast image. Other things will be like T1, that is CSF will be black, hypointense. But in this image, vessels will start appearing. As I told that in MRI, the vessels, blood vessels, arteries, they are not visible because the flowing blood doesn't produce signal. And in contrast MRI, those vessels start appearing. In contrast image, the blood vessels are seen. The blood vessels are not seen in normal non-contrast T1 weighted image as flowing blood doesn't produce signal. In contrast, enhanced MRI, blood vessels, venous sinuses appear white. So look for the locations where you are normally expecting blood vessels to be there, because in the cavernous sinus there is an internal carotid artery, there is a midline superior cestal sinus, there is a in sylvian fissure there is a middle cerebral artery, then there is a transverse sinus. You look for those places, and if that area is hyper intense and there is a, you can see the shape of the blood vessel, then it is a T1 contrast image. This image, all the images are T2 weighted images. This image I have placed to show that how coronal view appears and how the sagittal view appears. You see the first three columns, those are the coronal views. In the third image from above, you see both eyes are seen, as if the patient is looking towards you. And there is a nasal cavity, turbinates are also seen. This image where both eyes are seen, it shows as if patient is section has been taken from the front. So in coronal views, see the first, second, third, then in second row, see the first, second, third, then go through the third row, see, and go to the last row, and you see the first three images. It means these are all coronal views, and from nose, you see, from the there are vertical cuts in the coronal section from anterior to the posterior. When you go posteriorly, you see only these two cerebral hemispheres, or go in the fifth row, you see only cerebellum and this brain, cerebral cortex. And from it, just make sure that you start studying the coronal views. It starts from the nose, then it goes deeper to the level of eyes, then you enter the brain, okay, you see the ventricles, then you go posterior to the ventricles, you see the only cerebral cortex, and posterior fossa is also cut, and that is seen. Now go to the last three columns. Last three columns are basically sagittal images, which shows that as if patient section has been taken from the side. Easy to remember, side sagittal. Here you see, you can identify the eyeball, you can identify the nose, and that is a sagittal view. This is the MRI of the brain. Here there is a space occupying lesion in the brain. These are the axial views and sagittal views. The axial views are first three columns, and sagittal views are last three columns. It shows that there is a homogeneously enhancing extra-axial lesion on left side in the frontoparietal region. This is the, you see, there is a whiteness, hyperintensity, it is homogeneous. Moreover, it seems that as if this lesion is attached to the dura. Then the same thing you see in the last, you see the last row, fourth image, and here you can see what is the anterior-posterior orientation of the lesion. And bone is not seen, bone is hypointense because this is MRI. It is called extra-axial. Extra-axial means the brain parenchyma is not on all around the lesion. It means only on three sides you are able to see parenchyma. Therefore, it is called extra-axial. It is not intraparenchymal tumor or lesion. Moreover, why it is a typical feature of meningioma, which is extra-axial lesion. It theoretically it arises from the arachnoidal cap cells, but it is attached to the dura and gets blood supply from the external carotid artery, branches of the external carotid artery. And it is very much typical meningiomas are homogeneously contrast enhancing, and because it arises from the attached to the dura, a part of the dura also gets enhanced, and that is called dural tail sign, which you can appreciate in second last row, that is the 1, 2, 3, 4, 5th row, second image. You see there is a globular structure, but there are two tail like enhancement, what is that shows dural tail sign. These are the coronal images of the brain imaging, and this image itself is enough to understand the coronal section, structures which are normally seen in the coronal section of the brain, and how you can see the characteristics of lesion in MRI. Here you see the first image to the last image. You go through this, it shows that patient section has been taken in a coronal section, that which starts as from the nose, then both eyeballs, then you see the nasal cavity adjust low just below that, their nasal terminates are then. In the fourth image you see the maxilla, then you go behind, then you see both frontal lobes, then just behind that, just posterior to that, both ventricles, lateral ventricles start appearing. Then you go to the last image of the second row, you see the third ventricle appears. At the same time, you can also appreciate that in the fourth image of the second row, a hyper intense extraaxial lesion is appearing with dural tail sign, and it is causing little bit compression of the ipsilateral lateral horn of lateral ventricle. In the third row, you see the extraaxial homogeneously enhancing meningioma causing compression over the lateral ventricle and little bit of the midline shift, and the sulci gyri are not prominent on that side of the brain because of the edema associated with meningiomas. So again, to repeat those basic things, that for interpretation of the brain imaging, recognize the normal body parts which are being seen in MRI of the brain or spine. You can very easily recognize the eyeball, and on the sagittal image, it is basically a side, a lateral view. You see the orbit. In the coronal view, you see both eyes, and I explained it earlier that in T1 weighted image, CSF appears black. So if any abnormality is seen on T1 weighted image and the intensity is similar to CSF on T1, it can be a cystic lesion. If this lesion also becomes white on T2 weighted image, then there is a possibility that this lesion is cystic and it may contain CSF. This is the normal finding, and it is this characteristic is seen in any lesion, a very small cyst, or it can be a large cyst. This is the typical feature of arachnoid cyst. An arachnoid cyst doesn't show any enhancement after contrast injection in T1 weighted contrast image. So common occurrences on MRI, which are the lesions which are CSF like, it means on T1 black, on T2 white. The possibilities are CSF, chronic blood, edema, granulation tissue, encephalomalacia. In brain, there is no fibrous tissue. It is glial cells. If any area brain gets damaged, it is there is occurrence of the gliosis, that is called, because brain is also called encephalon, it is called encephalomalacia. It appears black on T1 and white on T2 weighted images. Mid-sagittal MRI brain image clearly shows the corpus callosum, pituitary, clivus, midbrain, pons, sella turcica, cerebellum, and fourth ventricle. There, the mid-sagittal image is very important, and it is very easy to memorize all the structures which are seen on MRI in mid-sagittal image. MRI is the investigation of choice for detection of the acute infarct in stroke cases. Acute infarct appears bright on bright white, that is hyperintense, on DWI, that is diffusion weighted image of MRI brain. On MRI, there is one sequence that is called flare image, flow attenuation inversion recovery. Flare is a very useful sequence, and in MRI brain you will find that the images where the edema is there, that will appear white, but the intraventricular CSF will appear black. It is okay. It is a like a T2, but intraventricular CSF appears black. It is very easy to identify the flare image by seeing the hyperintensity around the lesion, like in meningioma. If there is edema, that will appear white, and similarly if there is a transependymal seepage of the CSF due to increased hydrostatic pressure in obstructive hydrocephalus, you will also find hyperintensity just around the ventricles. MRI has a distinct advantage for the diagnosis of the neurological diseases, especially the tumors, degenerative diseases, some other lesions like multiple sclerosis, some infections. It has a very important role. Apart from the usual MRI, there are certain other MRI sequences which use some special techniques to give additional significance to the MRI imaging of the brain. There is one functional MRI. Otherwise, MRI is an anatomical study, but here patient is asked to perform some task, and like movement of the hand. As you know, all body parts are represented on the brain. Therefore, if movement of the hand increases blood supply to that area of the brain, and because you know that there is oxyhemoglobin, deoxygenated hemoglobin in the flowing blood, because of the activity of that area of the brain, if MRI images are taken, it shows there is a change in the intensity of that lesion. Therefore, it can predict that how far is the lesion from this functional anatomical part of the brain, that is called functional MRI. Then there is MR spectroscopy, MRS. It is a very common nowadays, and it gives a brief idea about the chemical nature of the lesion. It can differentiate neoplastic from the infective lesions. In like choline peak, a graph is created, and parts per million in that lesion it is measured, and on XY axis a graph is created. If there is a choline peak, it is probably a neoplastic lesion. If there is a lactate peak, it is a possibly a tuberculoma. Then there is another very important investigation, that is MR angiography, that is in brief called MRA. MR angiography, although doesn't MRI is a non-invasive investigation. It doesn't produce, it doesn't utilize any radiation, contrary to the X-ray or CT scan. Moreover, it utilizes only the magnetic field. Angiography, normally, when we call angiography, it means there is some injection to the vessels. But MR angiography is different. In MRI, as we know, that flowing blood doesn't produce signal, so that area appears black. A special technique is used, which it is utilized to visualize the those negative images of the vessels into positive whitish sort of thing, and you can see the blood vessels, and all the blood vessels can be seen. This is a good screening test for identifying some vascular abnormalities like intracranial aneurysms. But for the definitive diagnosis, our investigation of choice for intracranial aneurysm is distal subtraction angiography. In this slide, I have created a rule that you can call it a thumb rule. Fat is white in all sequences of MRI. You know that there is a intraorbital fat, just behind the eyeball there is a fat. So the MRI, in all MRI images, that area will be white, hyperintense. Then you know fat is there in the scalp. So the outermost, it looks like a hyper intense whitish thing all around the brain, that is fat. It is not the bone, because the compact bone appears hypointense or black. So bone, for detection of the bony lesions, CT scan is better investigation as compared to MRI. So that is why in trauma patients, where job is to see acute blood, job is to see the bony fractures, CT scan is the investigation of choice for assessment of the head injury patients. In MRI, the bone and calcification is black in all sequences. Air appears black in all sequences of MRI. Fat is white in all sequences of MRI. Structures which contain more protons, hydrogen atoms, appear white on MRI. That is hyperintense. The outermost white thing in MRI is a fat of the scalp. It is not skull, contrary to the CT scan. Fat is contained inside the orbit, so intraorbital fat appears white in all sequences. As you know, brain parenchyma normally doesn't contain fat, so any globular structure inside the corpus callosum
is if that thing is white in all sequences, there is a possibility it is the corpus callosal lipoma. Bone appears black in all sequences. The compact bones like petrous bone appear black in MRI. So MRI is not investigation of choice for head injury because one can miss the bony fracture. So CT scan of brain is the investigation of choice in head injury patients. In MRI also you see the whiteness or hyperintensity in some bones. It is because of the marrow which is inside the bone. Marrow is inside the skull is seen and one can have an idea about the bone. So the outermost layer, it is the fat of the scalp. Just beneath that, the hypointense black thing is basically cranium. Bone appears black in all sequences. The nerve content inside the bone is clearly seen. This is the added advantage of MRI because our focus is more on the soft tissue, on the nerve sheath tumors. This is the advantage. You can see the brain stem. You can see the brain stem is nerves emerging from the brain stem, like in the seventh, eighth nerve complex and cochlea content in the petrous bone is clearly seen as a white structure. So, to identify vascular or cerebellopontine CP angle tumor, MRI brain is the investigation of choice. What structures are clearly visible on MRI? These are A, as soft tissue delineation is better in MRI. It is very easy to identify different brain structures in different sequences of MRI. But to read MRI brain and diagnose different diseases, it is essential to the neuroanatomy. Brain anatomy can be described under following headings: cerebrum, cerebellum, and brainstem. Cerebrum consists of two cerebral hemispheres which are connected to each other with commissural fibers. The largest bundle of commissural fibers is the corpus callosum, which connects the two cerebral hemispheres. Cerebellum is situated on the posterior aspect of brain, that is below the cerebrum and behind brainstem. Brainstem comprises midbrain, pons, and medulla oblongata. In MRI, one can easily identify ventricle, which contains CSF, orbits, both eye orbits, eyes, brain parenchyma, it means cerebrum, cerebellum, and brainstem. They are venous sinuses like superior cister sinus, transverse sinus, and there is a choroid plexus inside the ventricle. They are dilated CSF spaces which are called CSF cisterns, and they are named according to the anatomical location like interpeduncular cistern, prepontine cistern, cerebellomedullary cistern, suprasellar cistern, Sylvian Fisher cistern, cerebellopontine angle cistern. These are the interhemispheric cistern. These are the dilated CSF spaces to protect the brain against the hard bony prominences. A large surface area of the neural tissue is contained inside the cranium or skull. It is possible because of large number of enfoldings which take the shape of sulci and gyri. The part which gives in is called sulcus and the elevated part of the cerebral cortex is called gyrus. This is a simple line diagram to show you the orientation of the axis and different parts of the central nervous system. Anterior, posterior, A1 and below, you can see how cerebellum is situated posterior to the brainstem. Brainstem contains midbrain, pons medulla oblongata. The brain is basically cerebrum and cerebellum, and then medulla oblongata continues in the spinal cord as a spinal cord in the vertebral column. This line diagram of cerebral hemispheres I have made to simplify the things. One should practice it very thoroughly and start with the first image. Create a shape like this brain and make only one horizontal line so you can understand what is the sylvian fissure. What is the orientation of frontal lobe and temporal lobe and what separates these two. Then go to the second image and draw another line, that is central sulcus. Now you are clear about the boundaries of the frontal lobe and you know the anterior limit of the parietal lobe. And in next two images you add lines. Then in sylvian fissure you create just a V-like structure. Now you have all the boundaries of the cerebral cortex and it is the beginning of the understanding of the neuroanatomy, and moreover it is very important yet very simple way of mastering the interpretation of CT scan and MRI of the brain imaging. You first understand what is frontal lobe, what is parietal lobe, then temporal lobe and occipital lobe, where is the frontal region, where is the posterior occipital region, and in this way you start appreciating the axial view, coronal view and sagittal view. So in many books you find lot of images, but and it the reader is perplexed with the complexity of the picture. But I told you earlier that just make a boundary of the brain. Then add first one line sylvian fissure, then add central sulcus and the perpendicular line. Then there is add a very simple small horizontal interrupted line, and now you add two lines, horizontal lines in frontal lobe, two horizontal lines in the temporal lobe. So it is very simple. By making two lines you have created superior frontal gyrus, middle frontal gyrus and inferior frontal gyrus. In temporal lobe again superior temporal lobe, middle temporal lobe and inferior temporal lobe. In parietal lobe it is a superior parietal lobule above this horizontal line and inferior parietal lobule. So this is the very much important thing, and it helps in surface marking of the lesion, it helps in the interpretation of the lesion, it helps in the surgical approach to the lesion. Okay, and you can understand the pre-central sulcus, then post-central sulcus, where is the motor strip, All these areas you can interpret by making this picture. In subsequent slides, you will see many sketched diagrams which will just to highlight the orientation of the different structures. Each image will give you some insight. Like in this, you can understand where is the anterior cranial fossa, where is the posterior cranial fossa, what is the supratentorial. Obviously, it is above the 10. What is infratentorial? Where is the foramen magnum? It is very simple investigation, but it is very good picture for interpretation of the MRI, especially the sagittal image. This image is shown as if vault, that is vertex of the skull is cut. It shows the anterior cranial fossa, middle cranial fossa and posterior cranial fossa. Sphenoid bone and petrous bone. Sphenoid bone forms the boundary of anterior cranial fossa. Petrous bone, the things behind petrous bone, is the posterior cranial fossa. And in posterior cranial fossa, you see a opening through which the medulla oblongata passes and then continues as a spinal cord, that is called foramen magnum. This image is the to explain the coronal suture, superior, that is the sagittal suture, lambdoid suture. Coronal suture is between the frontal bone and parietal bone. Sagittal suture is exactly in the midline, which separates both parietal lobes. And this sagittal suture is important landmark because just beneath it, between two folds of dura, a venous sinus lies, that is the superior sagittal sinus. This image line diagram shows the cross section because it is the axial image. Just to line diagram is made just to show how the cross sections are taken. If it is taken at the level of the ventricles, then both lateral ventricles and third ventricle is seen. If it is taken above that, then you will find only the two cerebral hemispheres. In midline there is a dura. These two line diagrams show that both cerebral hemispheres were separated by a dura, and then cross section at the level of ventricle showing two lateral ventricles, and two lateral ventricles are separated by a thin septum like thing that is called septum pellucidum. I have made this pencil diagram just to show that in midline there is a ventricle. In ventricle contains CSF, and just adjacent to the ventricle, adjacent to the this third ventricle, there are two thalami, and then if you go beneath this Sylvian fissure I have depicted as a black because it contains CSF. Just deeper to that there is a brain parenchyma that is called insula, a lobe, and then beneath that there is a lentiform nucleus, that is globus pallidus and putamen, which are the basal ganglia. And the similar thing has been explained in the second image also. This is a simple line diagram has been made just to show the orientation of the nose, mouth, then superior cystic sinus, corpus callosum, a bony structure clivus, then how pons lies over the clivus, then orientation of cerebellum, then the continuation of brainstem in the spinal cord. This simple diagram also explains how the pituitary tumors can be approached through the nose, that is called transnasal transsphenoidal surgery, or structures at the level of clivus can also be approached through mouth, that is called transoral odontectomy. The sagittal image of MRI is very important, especially the mid sagittal image. It shows all the anatomical structures which we normally think that they are the theoretical structures, but in fact we are able to see those things in MRI, like fornix, mammillary bodies. Those things are very clearly visible in MRI. Corpus callosum is seen in mid-sagittal image when the section passes exactly in the midline, and four party, all four parts of the corpus callosum is seen. That is, the anterior most is the rostrum, then bent, that is called genu, then body or trunk, and posterior is the splenium. The rostrum is attached to the anterior commissure, and fornix forms the floor of the lateral ventricle or roof of the third ventricle. Basal ganglia are the deep nuclei, mainly gray matter, consisting of compact collection of neurons. These are the caudate nucleus, lentiform nucleus. Lentiform nucleus has two components. Medially there is a globus pallidus, laterally there is a putamen, and these are the components of the basal ganglia. And in between the caudate nucleus and this lentiform nucleus, globus pallidus, runs the anterior limb of the internal capsule, and between thalamus and globus pallidus, the posterior limb of the internal capsule. This area is very important because most of the stroke patients are affected by either hemorrhage or ischemia of this region. So, to understand the neuroanatomy of the medial surface of the cerebral sphere, this picture is very important because many books may be having lot of complex things depicted in the medial surface, but one should start practicing. First, make the outer line of the cerebral hemispheres showing frontal, temporal, parietal, and occipital lobe. Then, in the exactly midline, you draw corpus callosum and draw few lines showing the fornix. In this way, you can appreciate the boundary of the lateral ventricle, and you then add something more in this picture and learn the medial surface cerebral hemisphere anatomy in a sequential and a systematic manner. This image is only the blood, this ventricles are shown, that how the lateral ventricle is placed, what are the parts of that, frontal horn of the lateral ventricle, occipital horn, temporal horn, then what is the shape of the third ventricle, that is a slit like, between how the aqueduct from the third ventricle to the fourth ventricle, there is a aqueduct of Sylvius, This line diagram shows corpus callosum, different parts of the corpus callosum, that is the rostrum, genu, body, splenium, then the fornix, and now I have added another thing, that is the pineal gland. You see the posterior aspect of the corpus callosum. Just beneath the splenium there is a pineal gland. Then you draw two prominences, that is superior colliculus and inferior colliculus. These are the parts of the midbrain, are they also called tectum, and just adjacent to that there is a CSF space. Okay, these are the colliculi. Then there is a fourth ventricle. Fourth ventricle is in the posterior part of the midbrain, pons and medulla oblongata. Now you see all the structures which are in the mid section, mid sagittal view. Now you draw the anterior commissure to which rostrum is attached. Then you see the draw the optic chiasma, and there are the recess. This in the third ventricle, it is optic recess. Then you draw the infundibulum or pituitary stalk. Then you see the orientation of mammillary bodies. Therefore, lateral ventricle, third ventricle, and boundaries and prepontine cistern, everything can be appreciated in mid sagittal image, and you can identify very small, very rare lesions in this area. It is the mid-sagittal section image in which you find below the corpus callosum is the lateral ventricle, and below the fornix is third ventricle. The floor of the third ventricle shows pituitary stalk. This picture gives an idea about the relation of the brain to the orbit, location of the pituitary gland, location of the pituitary gland as compared to the nasal cavity. This line diagram should be practiced regularly, especially the last image, where you can see boundaries of the fourth ventricle, location of the cerebellum, parts of the brainstem, that is midbrain, pons, and medulla oblongata, then cerebellomedullary cisterns. Then in second image you see the very simple diagram, but it shows all the parts of the midbrain, that is the two crus cerebri, then substantia nigra, then tegmentum, and posterior part is called tectum. Okay, this image is important to see the parts of the brain in MRI. Read this image and practice this image several times, and draw line diagrams yourself so that you can appreciate the sulci and gyri of the cerebral cortex. You can know that outermost is the scalp, then there is a skull inside, then the sylvian fissure on either side, then frontal horn of the lateral ventricle, just floor of the left frontal horn of the lateral in the cardiac nucleus. Then you draw a slit like third ventricle, which is compressed between two thalami. The green structure is the thalamus, and then adjacent to that is the lentiform nucleus, then claustrum, and deep inside the sylvian fissure is the insula. And you draw both occipital horn and frontal horn of the lateral ventricle, anterior hemispheric fissure, then posterior hemispheric fissure. A very small corpus callosum I had drawn just anterior to the two dots. These are the anterior cerebral arteries. This image is very important because most of the stroke patients come with the hematoma or ischemia of this particular region. In MRI, the majority of the structures which are shown here, they are clearly seen MRI, although that will be in the black and white and on gray scale. But if you know the anatomy, you can appreciate the anatomical structure in the MRI. This part will help you in studying the axial view of this image is made just to show you what is the parts of the skull, that is the anterior canal fossa, posterior canal fossa, middle canal fossa, then where is the sphenoid bone, because in MRI you will see some diseases, some bony erosions occur, like meningiomas. They are attached to the dura and they affect the adjacent bone also. Then in CP angle tumor you will find that there is a erosion of the internal acoustic meatus. Therefore this image is important. In first image you see grossly there is a middle, anterior, middle and posterior canal fossa and foramen magnum. Second image basically anterior canal fossa is slightly enlarged and just to show the how the anterior canal fossa is placed. Then in posterior canal fossa you see the anterior canal process, posterior canal process and part of the petrous bone. And in last image there is a foramen magnum, there is a internal acoustic meatus. This image is also important because in certain diseases like meningiomas, like cerebellopontine angle schwannomas, this orientation is good for the interpretation of MRI image. This simple diagram is made and no further detail is shown, just to give you the orientation that how the parasagittal view of the brain will be seen on MRI. This image is showing line diagram of the pons. What is the shape of the pons you can see. Then there is a dot on the posterior aspect of that is the part of the aqueduct running through it. Then your bone is made as a dotted line. It shows that cerebellum, pons and this bone has a relation that is called cerebellopontine angle, and in this area internal acoustic meatus lies and CSF is located in this. This is called cerebellopontine angle, and this is the very important structure for diagnosis of the cerebellopontine angle tumors, mainly the epidermoid, meningioma and acoustic schwannomas. Three membranes cover the brain and spinal cord. These are called meninges. The innermost is pia mater, middle layer is arachnoid layer, and the outermost is the thickest layer, the dura mater. Dura mater is also called the pachymeninx, and the arachnoid and pia are called the leptomeninges. Dura mater is tough, fibrous sheath, and it continues in the spinal cord also. The arachnoid is a thin, transparent sheath separated from the underlying pia by the subarachnoid space which contains cerebrospinal fluid. Brain floats inside the fluid and called cerebrospinal fluid. CSF is contained between these two layers of the arachnoid. Cerebral hemispheres, corpus callosum, brainstem, cerebellum are contained inside a hard bony structure known as cranium or skull. To protect the soft brain against the hard bony structures, there are wide CSF spaces at the base of the brain known as CSF cisterns. Cerebral cortex on surface can be divided into four major lobes: frontal, parietal, temporal, and occipital lobes. The weight of brain is about 1.4 kg and it appears as a soft structure. It is covered inside three coverings. The outermost layer is dura mater, middle layer is arachnoid layer, and innermost is pia mater. In between arachnoid and CSF, and in between arachnoid and pia mater, there is a subarachnoid space and it contains CSF. Broadband areas. All areas of the body are represented in the cerebral hemisphere, which is also known as broadband areas. These areas are given different numbers like motor area, sensory area, speech area, visual area, hearing area, etc. The commonly significant broadman's area are shown in this picture. You see the superior temporal lobe, superior temporal gyrus, area 41, 42, and then you see the in motor strip, that is area 4. Then there is a sensory strip just posterior to the central sulcus, that is area 3 to 1, and you can appreciate the posterior calcarine sulcus and occipital lobe where area 17, 18, 19 is situated. These are the common broadman areas. The important functional areas of brain are primary motor area or primary motor cortex or motor strip or precentral gyrus, that is area number 4. Primary somatosensory cortex, that area 3, 1, 2 are situated in the posterior central gyrus. Primary auditory area are transverse gyrus of Herschel, that is area 41 and 42. Broca's speech area, that is area 44, is situated in the dominant inferior frontal gyrus, which is usually left anterior frontal gyrus in right-handed person. Wernicke's area, that is receptive speech area, frontal eye field, and primary visual cortex area 17 in the occipital lobe. One should have idea about the arterial supply of the brain. Arterial supply of the brain can be described into two subdivisions. One is the anterior circulation and posterior circulation. Anterior circulation is contributed by the internal carotid artery and posterior circulation is contributed by vertebral arteries. Internal carotid artery is a branch of common carotid artery and vertebral artery is a branch of subclavian artery. Circle of Willis is a circle of arteries at the base of the brain providing major blood supply to the brain. It is named after the English neuroanatomist Sir Thomas Willis. It is formed by two anterior cerebral arteries which are in communication with each other anteriorly through anterior communicating artery. There are two posterior communicating arteries which are connected to the posterior cerebral arteries, and posterior cerebral arteries are the terminal branches of the basilar artery. This diagram shows the formation of the circle Willis. you can see two anterior cerebral arteries which are interconnected with the anterior communicating artery. The middle cerebral artery doesn't contribute in the formation of circle of Willis. Middle cerebral artery runs into the Sylvian fissure. Then there are two posterior communicating arteries. These are the branches of the internal carotid artery. The intracranial branches of the internal carotid artery are anterior cerebral artery, anterior choroidal artery, posterior communicating arteries, and middle cerebral artery. Then the posterior communicating arteries are connected to the terminal branches of the basilar artery, that is the posterior cerebral artery. In this way, the circle of Willis is formed and it is situated at the base of the brain at the level of suprasellar cistern. Then in this diagram, you see the both internal carotid artery and you see the formation of the basilar artery. Basilar artery runs just anterior to the pons and it is formed by union of two vertebral arteries. This diagram is made to explain the orientation of the internal carotid artery and vertebral artery in the neck. Internal carotid artery is a branch of the common carotid artery and it doesn't give any branch in the neck. When it goes into the cavernous sinus, and in the cavernous sinus it forms a siphon S-shaped structure, and intracranially it gives four branches, that the anterior cerebral artery, anterior choroidal artery, posterior communicating artery, and middle cerebral artery, that is the middle cerebral artery, anterior cerebral artery are the terminal branches of the internal carotid artery in the intracranial part. And you see the vertebral artery, which is branch of subclavian artery. It runs through the foramina in the transverse process of the C1 to C6 cervical vertebrae. In C7 there is a rudimentary foramen transversorium, but this vertebral artery runs from C6 to C1 and then it enters into the brain through foramen magnum. Vertebral artery which traverses through the foramen transversorium, that is an opening in the transverse process of C1 to C6 cervical vertebrae. The transverse process of C7 vertebra has only rudimentary opening. The vertebral artery enters the cranium through foramen magnum and two vertebral arteries unite to form basilar artery, which runs in midline just anterior to the pons, and at the upper level of the midbrain it divides into two posterior cerebral arteries. This simple diagram explains the formation of two vertebral arteries and the branches of the basilar artery. The branches, you can see terminal branches of posterior cerebral artery. Then there are certain pontine branches. Then one branch of basilar artery is anterior inferior cerebral artery, and then above there is a superior cerebral artery. These are the branches of the basilar artery. As MRI also helps in study of the some vascular abnormalities of the brain by having MR angiography, MRA, MR angiography. Therefore, it is very important to know the venous system and arterial supply of the brain. All the veins of the brain drain into the internal jugular vein, which drains into right atrium of the heart. But the venous drainage of brain is different from other structures in the body. The veins of the brain can be classified as superficial and deep drainage system of brain. One should have an orientation of the superior cystal sinus and transverse sinus, so you can understand the abnormalities of the venous system of the brain. The deep veins of the brain are internal cerebral vein, basal vein, thymostrate vein, great cerebral vein. If someone has an idea about the axial, coronal, and sagittal section of the brain, it becomes easy to interpret the MRI of the brain. The spinal cord is the continuation of the lower part of brainstem, that is the medulla oblongata. The medulla oblongata passes through foramen magnum, and in the as a spinal cord, it continues in the vertebral column. How to diagnose common neurological diseases on MRI brain? Once you have understood the normal anatomical structure and their appearance on the normal MRI, then you can diagnose certain abnormal structures or diseases of the brain in MRI. If the common infective lesions are neurotuberculosis, neurocysticercosis, and toxoplasma, or osteomyelitis, or any other granulomatous tissue like sarcoidosis, those things you can identify. You can also identify neoplastic lesions like epidermoid, glioma, meningioma, craniopharyngioma, pituitary adenomas, acoustic sarcomas, brainstem lesions, brain metastasis. Then congenital abnormalities like cherry malformation, hydrocephalus can be diagnosed on MRI. The vascular abnormalities can also be identified MRI, basically intracranial aneurysms, arteriovenous malformations, venous angiomas. Apart from the almost all the lesions you can uh, identify MRI with the help of different sequences. This is the MRI of a patient having arachnoid cyst in the posterior fossa. You see the posterior to the cerebellum or in the occipital lobe, there is a hypointense lesion. It is hypointensity, or intensity is similar to CSF, and it is on T1 it is black, on T2 it is white, and it is the arachnoid cyst. This is the MRI of the brain of a patient with arachnoid cyst. There is a CSF intensity lesion in the posterior fossa, just posterior to the cerebellum. You can see there is a hypointense lesion. The above three rows are sagittal images, and the below are the coronal images showing CSF containing space occupying lesion posterior to the cerebellum. This is a contrast enhanced axial view image of a patient which had a swelling over the scalp, and MRI showed that there is a enhancement of the granulation tissue, and it was a case of tuberculosis of the cranium. This is the coronal view of the contrast image of a patient which had presented with swelling of the scalp, and MRI showed there is a collection in the scalp, destruction of the bone, and granulation tissue which had enhancement over the frontal lobe of the cortex. In tubercular meningitis, MRI helps in the diagnosis. Contrast MRI brain reveals abnormal meningeal enhancement, leptomeningeal enhancement at the sylvian fissure, tentorium, obliteration of the basal cisterns, basal meningeal enhancement with basal exudates, gliomas in the basal meninges, ependymitis, hydrocephalus, calcification, and ring enhancing lesion. And because of vasculitis, there may be multiple infarcts. In MRI of the tubercular meningitis, there may be early changes in the form of ventriculomegaly, which is suggested by blunting of the frontal horn of lateral ventricles. The temporal horns become visible and size becomes more than 2 to 3 millimeter. The third ventricle is no longer slit-like and becomes globular. Sulci become effaced in the obstructed hydrocephalus. Hypointensity in the brainstem on TV2 weighted image may suggest features of ischemia. Hydrocephalus in TBM can be of two types: communicating type hydrocephalus and obstructive type hydrocephalus. In communicating hydrocephalus, the ventricles are enlarged, but you see also the enlarged cisterns, you see also the enlarged sylvian fissure and prominent sulci and gyri. But in obstructive type, because the ventricles are enlarged and there is a compression over the brain parenchyma, and there is the cortical sulci and gyri, they are effaced, and there will be less CSF in sylvian fissure and other cortical subarachnoid spaces. Periventricular hypointensity on T1 weighted image, which becomes hyperintense on T2 weighted image, is due to seepage of CSF fluid across the white matter and usually suggests hydrocephalus under pressure, which is an indication for CSF diversion surgery to decompress the ventricular system. This is clearly identified in FLAIR image, where just outside the ventricle you will see the hyperintensity. The common site of ventricular obstruction in obstructed hydrocephalus is aqueduct, that is aqueduct of Sylvius, causing enlargement of the lateral and third ventricle. However, there may be fourth ventricular outlet obstruction, that is the obstruction of the foramen of Laschka and foramen of Magendie. Magendie lies in the midline and Laschka on the lateral side, either side, leading to the pant ventriculomegaly. But there may be isolated enlargement of one ventricle also. Ring enhancing lesions on MRI are very common. The commonly seen ring enhancing lesions are due to neurocysticercus and tuberculoma. On T1 weighted MRI, tuberculoma may also appear as hypointense, which appears hyperintense lesion on T2 weighted image without a proportion edema in cerebritis stage. Mature tuberculoma show either ring or nodular enhancement with perilesional edema. Cageating tuberculoma, granuloma, on contrast enhancing shows rim enhancing lesion with cageation in the center. The target sign is the central nidus of calcification surrounded by ring of enhancement, and it is indicative of tuberculoma. This is the MRI of a 13-year-old child who had presented with seizures and deterioration of the conscious level and deficit. MRI showed there is a subdural collection, hypointense collection, which had peripheral enhancement and enhancement of the dura also. And patient was operated and with a burr hole, and pus was evacuated. This is this is MRI of a patient with very large arachnoid cyst. You can see the hypointense lesion in the temporal lobe. This patient was operated because there was a middle compression over the brainstem and patient had a severe headache. This is large temporal arachnoid cyst. This is the hypointense lesion around the sylvian fissure causing effacement of the frontal or on the lateral ventricle. This lesion is hypointense on T1 weighted image, suggestive of arachnoid cyst. A large hypointense lesion on one side of the brain causing midline shift. This is the appearance of the lesion on coronal views. These are the axial views in it is a T1 contrast image. Here the vessels are seen, but this lesion doesn't show any enhancement suggestive of arachnoid cyst. These are the diffusion weighted image of the brain. This picture shows the brain edema, cerebral edema, and types of herniation. Cerebral edema or brain swelling may lead to subfalcine herniation, tentorial herniation, and torsional herniation. This image, this picture should be practiced, which shows a large extradural hematoma, biconvex hematoma, causing midline shift, leading to subfascial herniation. That is a part of brain parenchyma going towards opposite side beneath the falx. Then you see there's a part of the medial temporal lobe is going below through the tent, that is the uncal herniation, and then a part of tonsil because of a lesion in the shown as a black lesion in the posterior fossa. Posterior fossa has limited volume capacity, therefore even a very small lesion may cause herniation of the posterior fossa structure, and commonly it is a cerebellar tonsil which descends beneath and causes compression of the medulla oblongata, causing compression of the cardiorespiratory center. These are very common findings in patients with very large space occupying lesions or in head injury patients, and MRI shows these features, and you can predict these things on MRI and then examine the patients, and patients may have bradycardia and hypertension and with respiratory irregularities, that is called Cushing sign. Therefore, MRI finding is very important, and all these structures are very clearly seen In MRI, subphyseal herniation, uncal herniation, tonsil herniation are very clearly visible in MRI. This diagram can be practiced to understand the coronal view of the MRI at the level of basal ganglia. This is a case report of a patient which had presented only with a scalp swelling, and when patient was operated we saw the bony defect which can be, this cranial defect can be seen in the second image, which is a case of brain metastasis. This is MRI of the patient which shows a scalp swelling which is hyper intense, and there is a cystic lesion in the cerebral cortex just beneath the lesion in MRI. First is the coronal view, a second image is the sagittal view. MRI is more costly than CT scan and is more time consuming. MRI machine also produces sign, and some patients complain of claustrophobia. Steel or ferromagnetic foreign material like bullet, metallic pellets or implants are contraindicated for MRI. Bone and acute bleed or hemorrhage or hematoma appears white in hyperdense in CT scan. Also, fracture of the skull or intracranial bleeding is easily diagnosed on non-contrast CT scan. Therefore, CT scan is the investigation of choice in head injury patient. Many patients of mild head injury insist on getting MRI, but it should be explained that whatever treatment is required in head injury patients, those things are visible on CT scan, not on MRI. Only very rarely MRI is required in head injury patient, especially in cases which have a chronic subdural hematoma at one stage. Sometimes it is missed. Therefore, in those cases, a bilateral chronic subdural hematoma at particular stage, MRI may be required. And in patients where CT scan is relatively normal, but patient is on ventilator, it means it is not explained. Therefore, in those cases when patients become relatively stable and can be shifted to for MRI for half an hour, which takes at least half an hour, in those cases MRI may be required to explain, and it usually comes out to be a diffuse axonal injury which can be seen in MRI. This is the one indication for head injury, one indication of MRI in head injury patient. As I explained, only in few cases of head injury like diffuse and axonal injury, MRI brain is required. Many patients of head injury want MRI brain, but they should be told that whatever finding on neuroimaging in head injury warrants neurosurgical intervention in head injury can be seen on CT scan. Functional MRI is similar to the normal MRI, but it highlights the functional area of the brain. It is based on the principle that when an area of the brain is in use, the blood flow to that region increases. So the neuronal activity changes in the blood flow, that is hemodynamic response, and which in turn changes the magnetization between oxygen rich and oxygen poor blood. fMRI uses the blood oxygen level dependent, that is bold contrast, and maps the neuronal activity by imaging the changes in the hemodynamic response of the Brain area. Neurosurgeons may use functional MRI for pre-surgical planning for lesions close to eloquent area of the brain, for example, motor area, speech area, etc.